Also, I'm not a millennial, so this reminds me of Janet Jackson. I have thought of a lot of intros, but I think my best is to say I'm Randall, like I said. I'm a nursing sister, I'm a man, and I'm married to a pastor. She is a woman. So thank you for inviting us. It's an honor. Thank you for BADM. Thank you to the organizers and the donors and everyone that played a part. We hope to inspire you after this talk.
Good morning, everyone. My name is Clint. We've been working together for ±5 years. I see on the program this is a debate. Our debates usually end in violence, so I think I'm going to lose this one. So let's keep it peaceful. Okay, so we're going to start by doing a quick poll.
So as part of our start, I have a history of working in public health as well as in private. I would like to know, by a showing of hands, and this is by choice, red means danger, so red will be private healthcare. And currently I'm working in public health, so green will be public health. How many of you are working in the private health emergency care facilities? And how many of you are working in public health? Can you keep up your red ones? So we are standing strong. Okay.
Okay, that's interesting. For the second question, I want you to think of your own scenario where you work at. I want you to think about your collaboration and communication between the doctors and the nurses on the floor. Who of you feel that there's a them and an us? Who of you feel that there's things can improve on? Red. Who of you feel that it's absolutely perfect? Green. Thank you.
So I'm glad I'm working in a trauma unit where I can be resuscitated. So I would like to ask, considering the management from the guys on the floor, be it the emergency medical, the MOs, and the nursing sisters, the staff nurses, how many of you feel that there's a good communication between the operational management, the physicians or the consultants, towards the vice versa to the staff on the floor? Red for no, and green for yes, it's good. I have a very strong team working in the EC.
Okay, and lastly, just very briefly, the communication collaboration or the feeling of being one team between the people on the floor, that's us working on the floor, and the management of the hospital. Bad? Good. Thank you.
So in the Department of Health, which I'm proudly part of, we have a vision that says, let's work better together. Being the husband of a pastor and being placed on a straf. I don't know if you can understand the Afrikaans word, being reminded of your sins. I would like to bring a short portion of a spiritual encouragement where it says, when I was a child, I was thinking as a child. I understood things as a child. Or I was speaking as a child. So if you look at the word speak, understand and think, and you take the first letters, S-U-T, S-U-T. We are working in a system where we have a bunch of red cards because of our communication. That's the system. So the S-U-T currently, it's a system under test. We need to find out how can we improve the collaboration between nurses and doctors, management, EMS. We need to understand, when we started our careers, do we still speak the same way that we did when we started our careers or when we were children? And do we speak differently now? Do we understand what to say to each other? Do we speak the same language in emergency care from EMS, but now currently in the nursing setup versus the doctor setup? Do I understand what the doctor's train of thought is? Do I understand why they want things to be done quicker now? Or do I understand why they are willing to wait on certain things, waiting times? And then also, the T, do I know what they're thinking about? Do they know what I'm thinking about when they ask me to do something? Do we all understand what the collaborative thought is to reach this common goal of a very competent emergency care towards our patient.
Good. So basically what we are doing, the emergency care we're providing, can be summarized in this slide. It's all about access to care and quality of care. So if we have access to everyone and we get quality care to everyone, that's our goal. How we measure, that's our own thing. It doesn't matter if we have good systems and good IT systems and measuring and everything and policies. If we don't communicate good, it means nothing. It doesn't filter down to the patient. So if you look at this, what we're actually going to talk about today is not the coverage or the effectiveness of the impact. We're going to talk about the we. We don't know how to we. You showed this morning with your red cards, isn't it? So we've got good systems, bad systems, good innovation, technology, but we don't know how to we. And we don't emphasize, and this is what we're going to talk about today.
Yeah, so studies have shown that a good nurse-physician communication or the setup of teamwork, it improves the job satisfaction. So if we understand why the doctors did what they did, if the doctors understand why the nurses come in to do what they do, then the whole understanding of each other then improves the job satisfaction in our setup. Then there are certain things where we need to understand what better patient organization, how our collaboration can improve the outcomes for the patient. So we will look at, if we do not understand what the other person does, it increases the length of stay of the patient. Or if we have a good cohesion, I'm about to say my broer, it's a bad habit. So if I do say my broer, please sorry. I come from just plain. So if we can understand each other, if we can understand why we do what we do, we decrease the patient's stay in the unit, and currently we have a bad history of length of stay in our emergency centers. But also if we do understand and we can work together, then we reduce the effects on the patient, the reduction in treatment costs. It takes a lot just to manage one person in an emergency center, especially if we can resuscitate them and they stay for more than 24 hours there. So we have also found that we have a new generation coming up, the millennials. I am not a millennial, I'm far from it. So we have found that the millennials, our younger sisters, if they pick up that a doctor is not very nice to them, they are going to come and tell us. They will even tell the doctor, I don't agree with how you are speaking to me. The older person like me, we were taught, we come from a generation where we go to the office, we sit and we think, that wasn't nice. We go out and we live life again. So I think we need to understand that we need to discuss and make known what didn't I like, what happened just now. And that is the improving of communication. So when we have all these problems, how are we going to look at problems from a perspective where everyone is involved? And I think the one thing that we would like to boast about in our EC is that we received a few accolades and compliments where we have this thing that we call a huddle. If we have a huddle, then everyone comes together. We call the porter, the security, the cleaner, the nursing sister, the staff nurse, the ENA, every category of staff, we have access to go to the huddle and you can share your concerns. You can share what you are unhappy about. And you can share to say, I actually think that what yesterday's research was a success because of this or that reason. So if we have this forum where we all can come together and share our feelings, then we have a better outcome and a better team cohesion.
Good. So I'm just going to touch on what I said earlier on. So we've got many different policies, protocols, guidelines, and so on that helps us to do what we do. But it's extremely important to realize that if we don't communicate good at the floor, that doesn't filter down. So it doesn't matter what policies we have. The problem is we invest a lot of time in these policies and training and so on, and we don't invest a lot of time in communication, in our structure, in how we communicate, how we get information across. There's the National Development Plan, for example. This is a very complex plan. There's the NHI. Lots of big policies, but without good communication, there'll be little little effect or little bad implementation. They're doing a resuscitation at this moment. Very complex procedure, isn't it? Interplay between teams, interplay between people. They are practicing how to we. So they're not reading textbooks and or looking at videos and then they get certified. They're actually practicing how to be a team leader, how to communicate, how to get the closed loop. That's practicing how to we. So if they're doing it for resuscitation, why are we not doing it for the more complex things? We take it for granted. We assume that we know how to we, that we understand the other one, that they get the idea. So let's continue a little bit. So one of the reasons we think why we have a problem with communication, if you look back in history, then, back in the days, 20 years ago, we're not going to give away our ages. There were no emergency medicine. There were no emergency medicine specialities, no emergency centers. There were no 24-hour doctor covers. You have your typical rural hospital that's completely run by nurses. The doctor's often at home. They call them out for the serious ones. The nurse can manage most of the things. And they were responsible for all operations and managerial stuff and a lot of the clinical work. Today, things have changed slightly. So now we have emergency medicine, we've got emergency physicians, specialists, we have people who do diplomas, who upskill themselves. Our knowledge base has improved vastly. A lot of people know a lot more about emergency medicine now than a while ago. There's training, there's an academic environment, and the clinical work has shifted more towards the doctors, not in the rural areas as much. But what hasn't changed is the communication structures and the organizational structures. Everything comes from the previous system, and that is why our communication system has not advanced or evolved with the change within emergency medicine. And that's what we feel is one of the reasons why collaboration and communication is not good. Just to demonstrate to you how dysfunctional communication can be, we're going to discuss a brief scenario. So for us, and for all of you maybe, to implement a change in the emergency department, to say, listen, come let's work on something. This is what usually happens. So it's me over here, somewhere here. So we have an idea, we chat about it, this and this and that. Then I'll go to my line manager. I'll say, listen, I've got this idea, blah, blah, blah. What do you think? Say, oh, it's a great idea. Then he feeds back to me, and then what I'll do, I'll go and discuss it with my operational manager.
So when it comes to me, it is expected of me then, I must speak to my shift leaders. I inform them what was the plan, what's the suggestion. I then expect them to speak to their lower categories. Because if you're in charge of 4 shifts, it becomes a challenge to get the same message or to get everyone to hear what the plans are, especially with your night shifts. If the feedback comes to me, it is my responsibility then to go and speak to my area manager. She's in charge of a few specialty wards in the hospital. She then has to go to the nurse manager. They then discuss what is Mr. Rhodes' suggestion, what did Randall ask for. They then discuss, is it feasible, do they have any suggestions, do they have any opinions. They then feed back to the area manager back to the operational manager. Operational manager, if it was what we as doctors and nurses decided together, then we come to a forum amongst each other. When we have made our decision, then we go back to our lower categories. So if you look at it, there's a big up and down that goes as the communication goes on.
Cool.
If there is something that has to do, that might involve the infection prevention control, the health and safety, then I step out of my office, I go to the next level of management. I share with them what would the EC like to do. They then sometimes have to inform the top management, this is what EC would like to do. It goes up and it comes down again. And then it's horizontal. So there's a lot of challenges in communicating changes sometimes.
And what happens right at the top, so when I go to my line manager and he goes to his, there's very little communication between them. So the direction or the suggestions go back down and go sorted out at the bottom. To summarize what we've just chatted about now, if you have 2 lines of communication, for argument's sake, doctors and nurses, this is what we're basically spoke about, say the junior staff and the senior staff on the floor, the EC managers, area managers, and so on. Below the line is what happens on the floor. Between the lines are the EC managing and the EC management. Above the lines are the hospital managers. So just to summarize what we've just done now, we'll speak to each other, and at the same time, Mr. Rhodes will speak to his senior nurses. Then we'll get together and chat. Then I'll go to my line manager. He goes to his line manager. Sometimes he goes to the area manager. Sometimes he goes to the IPC, etc. Then they take it a step higher, and then they take it to their EMT person. And once they are happy with it or not happy with it, they send suggestions all the way down, and then we chat again, and then the whole process repeats itself. You see what I'm saying? So this is typical of a hierarchical system. I'm not saying it's bad, but I'm saying this poses a lot of barriers to actually to functional communication on the floor. There's a lot of barriers to actually make it work. Oops. So there's a lot of evidence that say this way of communicating, the up and down, and then one is not as great as doing it this way. Having a joint opinion at the bottom, so having representatives and say, come, we chat about this, and then saying, what do you guys think, and only have one communication. So this is a lot more functional, it's a lot more logic, and this will probably break a lot more barriers. This is what we strive to, and we're not saying the other system is bad, we're saying this is probably better. Okay, so now we're going to talk about a few pearls. We've got a few minutes left. A few pearls of how we think we can improve communication, collaboration amongst each other.
Okay, so currently we have joint huddles where nurses, doctors, and everyone comes together. But we also, from a nursing perspective, I have a huddle every morning where I ask the guys what happened yesterday. What did you feel what went good yesterday that we can boast about, or what went bad yesterday? So that's a nursing huddle. It's every morning. Sometimes I've been told, Mr. Rhodes, this is too long. But if you look at the value of coming together, each one has an opportunity to raise their voice. Each one has an opportunity to say what were they happy about and what do they feel we really can improve on. If the information comes, it is my responsibility to follow through on what the suggestions were. I will then go to my doctors and share with them this was a concern, and then we strive to have the concerns resolved. People must have an opportunity to raise their voice of concerns. So as you see, that's a picture of a joint huddle that is in our emergency center. That's to the majors area. So we have our registered nurses, our doctors, our junior doctors, our visiting doctors. We all come together and then we discuss. This is the one thing that created a big change in the perception in our EC, where we have a huddle. Even your porters felt very accomplished if they could be able to say, I feel if we push a patient to the x-ray at this specific time, or I will wait for you guys, it improved the flow of the patient. In involvement projects, it is good for us in our setup where if there's a suggestion, if there's a plan, it should not just be the operational manager that goes and be part of it. We have embarked on so this talk is not just about me just playing this. We are sharing that with what everyone can do. We have embarked on projects where we ask some of our not managerial nursing sisters to be part of certain groups in the hospital. If you're going to develop new resource policy, if you're going to look at how do we approach certain IPC challenges, if everyone can be involved and say from their side, then it is the hospital that's making a change, not just the doctors or not just the nurses. Most important, this is the one thing that I like. I always say to the staff, if you walk from your unit to the shop, ask anyone else if they want to come and work in the EC at Mitchell's Plain, and they will say, no, I will not go there. So every nurse who walks in the EC, if you go, you must walk with your head up high because you are a superhero. That's what I feel from my nurses. If you identify someone who likes their area, if you see this person likes doing this trauma, then we motivate and we fight and we try. Let this person go and specialize. If they come back, it will just be to the benefit of our patients. Not just necessarily to specialize in anything, but smaller things. If you want somebody who wants to come and speak about disaster management, then we allow them to go and speak about, develop something for disaster management. Very exciting and very strange for nurses sometimes. What we have done, so we would press our pediatric resus button. It's a nice setup. Our peds resus is far from where the majors are, so we press the button and see how many nurses actually respond. How do we do we know how to wee? Or do we only expect the doctors to respond to a button that goes off? So we will press the button and see who comes, will there be any nurses or is it only doctors that respond? There were times when we, in our actual majors area, currently we're sharing majors and resus, and we have a simulation of resuscitation. If you have this simulation in the actual environment, then you see how people will also act when it's an actual resuscitation. So then you can see how does the nurses think when they do what they do? How does the doctors think when they do what they do? And how can we improve this collaboration between nursing and doctors? Very important. So I have a group of nurses and EMS. There's a very good relationship between them. So you'll find that they will go and do certain activities outside. They will socialize together. Some of our doctors, they join them. So, say again? So they go and they shoot each other with paintballs, not real bullets. So the idea of having this team building and coming together means that even when the EMS guy comes in, like the previous speaker says, no, I don't want anyone to turn around because we don't know how serious the patient is. We don't know what the EMS guy had to go through. Did they have to duck and dive for some bullets? And now when the EMS comes into the unit, do they know what we have to go through with some members of the public that were so rude towards us because they're waiting for 4 or 5 hours, but we're resuscitating 6 patients. So team building is very important. And the current picture that you see is what we as a hospital did. And we all know about wearing black yesterday on Friday and the week before. It is us as a hospital coming together for the social evil of violence against women and children. It just the cohesion becomes better if we agree on the same concerns in our hospital. Shame. Communicating the challenges that we face. So it was very interesting to realize that some of our doctor colleagues didn't understand what the nursing sister and the nurses has to go through in order for the unit to function. So it's easy to come and say, please can I have ceftriaxone for that patient? But in the meantime, the nurse is busy counting drugs. Do we understand the medical legal implication and the Pharmacy Act laws and all those things? If the drugs start disappearing, it's a bad thing. Do you understand why the doctor needs you to go and respond to a certain thing? In our setup, if you are a registered nurse, you can specialize, but if you are an assistant nurse, you are being placed in an area. Does the doctors know that it was maybe not the nurse's first option to work in an emergency center? She maybe wants to work in a pediatric ward, but now because there's a post, you are being placed in the post. So do we understand what causes my stress if I'm in my work area? And do I understand what causes doctor stress if he's asking for certain things to be done? And that's where communication comes in.
Good. So those were suggestions, pearls of wisdom that we can do on the floor. With regards to the EC managers, the next level, there's another consultants and the operational managers. What we can do, we need to have one voice. So if the nursing fraternity has their operational manager, and the doctors has their operational manager, and the porters and everyone, it gives the impression that everybody has their own agenda and their own priorities, and that will filter down right to the bottom. So having joint operational meetings, for example, sounds like a very simple intervention, but it has a big impact. It feels like we're one team, we've got the same priorities, or you bring your priorities, we bring our priorities, and we work together, and we have a joint thing. So joint operational meetings, I think, is imperative for good communication between the senior leaders of anything. It is, and the value of having one goal and one vision is underestimated. If the nursing leaders have one vision, this is what we want to do, this is our priorities, and the doctors have, and the porters, and the security, and everybody has their own priorities, and it's not aligned, it creates the feeling, especially to those at the bottom, that we're working for multiple people and multiple fraternities. If we have one voice, one vision, this is what we're doing. This is our list of priorities. This is our strategic planning for the next year. This is what we want to achieve together. Very few things on just involve nurses, and very few things just involve doctors. There's always interplay. Anything that involves patient care involves both sets. So it's advised to have a clear list of priorities with input from everyone, one vision, one goal, similar strategic planning, similar goals, similar vision. And it's important to share that vision, one voice. So if someone, for example, say, I want this from the EC, there must be one answer. What are you doing? One answer. Even if we speak down, it's one answer, not that one says that one says this team. It's one vision, one team, and one voice. When you go to the next level, so the EMT and the hospital managers, so it's quite difficult for them. And my suggestion is they need to realize, the first thing is they need to realize that we've realized today, communication is not what it's supposed to be. We don't know how to be. They need to realize and understand that what they say and what they want us to do and what they think we should do or are doing probably isn't happening because of this big barrier, because the structures at the bottom, the structure of communication is not perfect. Once they've realized that, they need to invest. They need to invest and say, how can we help improve that? We're not suggesting a whole system change overnight, but we are suggesting that people start talking about how to we, and not only about what to do. And our closing statement is actually a challenge. We would like you to go out to your own area, wherever you are working, even if it's not in the EC, and think about communication between each other, think about communication between line managers, think about these barriers, and don't take it for granted. Invest in improving it, invest in looking for barriers, invest in good communication, good structures. That's my challenge for you, that's our challenge, and we thank you.
Okay. Can I see the last one? Okay. Before I get addicted to hand claps, I would like to share, with my first time that I attended a bad EM conference or symposium, there was a nice saying where they said that the standards that you walk past is the standard that you keep. And that is something that I shared with some of the staff at the hospital. And I saw something very interesting. I think it was the Steve Jobs quote that they left there, that the client is not interested in how hard I have tried to reach this goal. They just want to see what is the result for them. And for us as emergency care practitioners, the behind the scenes, I would dare to say the best way that we can know how to be is to drink a lot of coffee. But do we know how to actually work together? With all our challenges, the patient wants to know how best can you treat me, despite our best efforts. We must just work harder from our side.